So urology doesn't seem like much. You probably think of us like just these happy jokesters who deal with urethral strictures and elevated PSA. But there's a lot to urology. We've got men's health issues, pelvic health issues in women, cancer screening, how the plumbing actually works, the nerves involved in the plumbing, pediatrics, and we've got infections, hematuria, urinary obstruction, pain. So it's actually bigger than most people think about. We have subspecialties in urology, but most urologists are actually practice general urology, where they do a combination of these subspecialties. And just for the numbers, there are about 12,000 board-certified urologists, and about 11,000 are in active practice that do more than 20 hours a week. Urology is an older specialty. Even though I've got younger people here, they're below the average, because urology is an older specialty, with the average age being 56. And we need a little love, because those of you who looked at the Medscape burnout survey saw that burnout in urology, 54%, and we're number 1. So that's kind of hard to explain. We can talk about that if you have questions about that. Nobody really cares much. Urology is only 1% of all doctors, but it's a big deal to us. So we need a little love, okay? And there are more urologists retiring right now than are filling those spots. And this is urology for everyone, because everyone needs to know a little bit of urology, if not for themselves, for their patients. So our program here at Loma Linda, we serve 5 different hospitals: the VA, the county hospitals, the university hospital, and also we're involved in the community practice with the Beaver Clinic at Redlands Community Hospital. Our urology residency program is 2 per year, recently expanded. We got the approval for 3 per year, so we'll be growing, and we have an endourology and minimally invasive surgery fellowship. So urology and lifestyle, that was the charge. Well, urology and lifestyle, it could be summarized as whatever is good for the heart and the brain is good for the urology apparatus, okay? So that's a take-home message. Pay attention to the cardiologists, pay attention to the Alzheimer's people, and that makes below the belt and the kidneys work the way that they're supposed to. One other thing, everybody's talking about opioids, and we're kind of taking that more seriously, because it's estimated that 5% of post-surgery patients will go on to develop an opioid use disorder. So we look at that and we say, well, that's probably high, that couldn't be us, but those are the statistics. And the other thing, the Riverside San Bernardino area is 4.6 million people. That's about like Oregon. And our particular group that we serve and minister to has lower education and income, and there are several than average in the United States, and there are several local cities that made the top 50 miserable cities to live in based on income, education, and crime. So we feel like, though we're not always out in a foreign country or Africa, we're doing our part here. So we now have 22 faculty, 18 adult urologists, 4 pediatric urologists. Our board pass rate is 100%. We're active in peer-reviewed journals, contributing to things like Southwest Oncology Group, collaborative studies, and we have third-year medical students on our service. So to introduce the panel, Duane Baldwin. He does endourology, minimally invasive, and robotic surgery. He did his residency at Loma Linda Fellowship at Vanderbilt, and he's the Endourology Fellowship Director. He is a professor. Brian Hu does urology cancer. He did his residency at UC Davis, Fellowship at USC, and he's the Associate Residency Director and is an assistant professor. Andrea Staack, female pelvic medicine reconstructive surgery. She came to us from residency in Germany from Berlin, fellowship at UCLA, lives in Redlands, and is an associate professor and is an important medical student mentor. So with that, we've got first up Dr. Baldwin.
All right, can you hear me okay? Great. So today I'm going to talk a little bit about kidney stones and some new developments in the field of endourology. These are my disclosures. And by way of outline, we're going to talk about a little bit about epidemiology, then treatment. We'll talk a little bit about controlling pain. Kidney stones are very painful. And then we'll talk a little bit about cost and some future technologies. So kidney stones are extremely common. It's estimated in 2015 there were 22 million cases worldwide with 16,000 deaths. And if you look at the graph on the right side of this slide, you'll see that this is a disease that's more common in developed countries. And in fact, it's increasing about 1% per year. It's increased 16% between 1997 and 2012 in the US. And of concern, the people who are increasing the most are the populations that didn't used to get stones that much. It's children, where the incidence has doubled, and women, where it's increased by 45%. So we're all quite familiar with the evils of metabolic syndrome, and perhaps, as Dr. Ruckle said, what affects the body also affects the kidneys. It's not surprising that people with metabolic syndrome have an increased risk of kidney stones. And if you have 4 of those traits for metabolic syndrome, you're 1.8 times more likely to get kidney stones. No surprise, smoking and lack of exercise contribute to the development of metabolic syndrome, which contributes to the formation of kidney stones. So, what can you do to avoid formation of kidney stones? Well, eating a good diet. The question is, what is a good diet for kidney stones? And for each type of kidney stone, there may be a different diet. So to kind of simplify it, in general, we tell patients drink 3 liters of water a day, limit your animal protein consumption, and reduce the salt in your diet to 2 grams or less per day. Losing weight will also decrease the risk of formation of kidney stones. I was very conflicted for years because I would tell my vegetarian patients they were at increased risk of kidney stones because they were eating all these nuts and all these green leafy vegetables that are high in oxalate. The most common stone is calcium oxalate. But I'm pleased to share with you this paper that just came out this year in the Journal of Urology. This is Ryan C., who was a graduate of Loma Linda's medical school. And he looked at a population in China with 75,000 women and 61,000 men, followed for a mean of 8 years. And the good news is they actually found that vegetarians were at a lower risk overall of stone formation, probably because of the reduced consumption of animal protein. So if someone does form a stone, how do we treat it? There's 3 main modalities we use: shockwave lithotripsy, ureteroscopy, and percutaneous nephrostolithotomy. In general, stone greater than 5 millimeters will need treatment. Briefly, I'll just show you how each of these works. This video is supposed to play automatically, and it doesn't, but basically, it is on yours. Okay, good. So basically, the machine conducts a shock wave through this liquid medium to the kidney, and the stone is very brittle, so the stone breaks up, and then the patient passes the pieces. It's the most non-invasive method we have for treating kidney stones. So the second option is ureteroscopy. And in this procedure, what we do is we put a little scope. This is a natural orifice procedure. So we go through the normal channels into the urethra, we put a guide wire, we pass the scope up. Here you can see us looking around in the kidney and using a laser to break up a cystine stone in this patient who had cystinuria. We recently just did a review of 364 ureteroscopy patients that we compared to 444 shockwave lithotripsy patients, and we found about a 17% higher stone-free rate with ureteroscopy. You can see the complications are quite similar and fairly low, but also of concern, you can see we've developed techniques to do ureteroscopy with very small amounts of radiation exposure. In contrast, there's 96% more radiation if you get a shockwave lithotripsy than if you get a ureteroscopy at Loma Linda. For large stones, usually over 2 centimeters in size, we do a procedure called percutaneous nephrostolithotomy. And this procedure traditionally has required tremendous amounts of radiation exposure. In fact, we went back and calculated for a 5-year period the amount of radiation that our patients were exposed to. And when we added up the radiation from all the different parts of the procedure, it came out to 39 millisieverts. That's a number that probably doesn't mean too much to many of you, but that's the amount of radiation you'd get if you had been in Hiroshima when they dropped the atomic bomb and were 2.5 kilometers away. So we weren't happy with that. We weren't satisfied with that. So we developed some techniques to lower our radiation. So the first thing we do is we use ultrasound, and we map out exactly where the kidney is. You can see that white to the left, that's the lung. We want to avoid the lung. And then we put a scope up on the inside of the kidney and use just a couple taps of fluoro to center that little clamp that you see in the X-ray picture over the tip of our ureteroscope. And then we can use the laser that comes out of the image intensifier of the C-arm to direct the needle. We can have our hand in the beam. The surgeon doesn't have to worry about getting radiated. And you can see us making course corrections in this video, advancing the needle in, keeping it aligned with that laser trajectory. And as we push it, you'll see it pops right there. That was the feel that we get when it pops into the kidney. Here you can see the saline is coming out. We know we're inside. We can then pass a little wire, grab it. And this is one of the steps that would take minutes of fluoro to try and get the wire to pass down the ureter. But we can do this easily with no additional fluoroscopy. Once we're inside, we laser up this, break up the stone. So this is like a jackhammer, and it also has ultrasound. So it's 2 modalities together. You can see it makes rapid work of this stone, breaking it up and liberating this stent, which was the cause of the stone in this particular patient. And we were able to get that stent out of there. So if we look worldwide at the use of these 3 techniques, you'll see in this graph, the blue line represents shockwave lithotripsy, which is decreasing in frequency. And the red represents ureteroscopy, which is increasing in frequency, probably for the very same reasons that I just presented, the increased success rate of ureteroscopy and decreased radiation exposure. And you can see that kidney stone percutaneous nephrostolithotomy is increasing at a slow, steady rate. Well, once you have your stone treated, you go home and you need some medicine to help with your pain. Dr. Ruckle already mentioned the opioid crisis that is occurring in America right now. And it's estimated in 2016 there were 42,000 opioid-related overdose deaths, and 40% of those were on prescription medications prescribed by a doctor. So this is a major problem. The American Urologic Association in 2018 said, well, we need to give the least amount of narcotic medication we can, but no one had really said how much was that. So this is a paper that just came out. This is from Johns Hopkins, where they used a modified Delphi approach to get all the stakeholders together to try and figure out how much narcotic medication we should use for kidney stone patients. You can see from that table, they estimated that for most procedures, you only need about up to 5 pills, and many patients don't need any. Dr. Ruckle actually wrote the editorial comment for this paper. So other authors have taken it even a little bit further. And this is a paper from University of Vermont, where they found that 75% of the time, they could treat kidney stones, do ureteroscopy with no narcotics at all. And I'll tell you that we gave up narcotics for our ureteroscopy patients about 2 years ago, and they're doing very well. And in this study, there was no increased phone calls, there was no increased visits to the ER, and in fact, there was less requirement for additional narcotic medication. So all these stones being treated are costing quite a bit to the healthcare system. We wanted to get to the bottom of ureteroscopy, the most common stone procedure. Stones are costing about $3 billion a year to the healthcare system. So we reviewed 109 cases in detail. We found out that the cost to the hospital was about $2,900, and about 3/4 of the cases made money for the hospital. When we did a multivariate analysis, the only thing that predicted the overall cost of the procedure was how long the procedure took. So clearly we need to be faster. But then the next question is, well, what is responsible for the procedure taking a long time? So we went back and looked at that, and we found out that if there was a resident on the case, it added $516 to the cost of that procedure. And if something the hospital does routinely, if there was no designated scrub tech in that case, that increased the cost $1,100. So a major problem. So in the last couple seconds, obviously with all these stones, is there anything coming on the horizon that could make us treat these more efficiently? Here at Loma Linda, we had the honor of being one of the first 4 sites to get a brand new laser technology called the Thulium laser. And this laser, the traditional laser, will only go to 50 cycles per second. This laser goes to 2,000 cycles per second. So it's kind of like, hopefully on your, you'll see on this video, you can see the difference. So the thulium laser, as fast as you touch the stone just kind of disappears. And it doesn't fragment, it just vaporizes. And so there's not debris clouding your vision. There's not pieces that you have to pass. So is this faster? Is it better? We tested it in a benchtop model. Compared to the conventional laser, breaking up a 1 centimeter stone, we would save $1,100. So yes, the answer is it is faster. Well, in robotics, we have many robots. They're a mainstay of surgery nowadays. But there's a new robot, as you can see here. This is the single port robot. And its little arms come out and establish triangulation for you through one port. And robotics is even making its way into ureteroscopy. This is a robotic lever that deploys the ureteroscope. So the advantage of this is the surgeon can sit there comfortably at the console, and he can be removed remotely from the sources of radiation, and hopefully won't have to get brain cancer like many interventional cardiologists and other physicians who use fluoroscopy. So in conclusion, kidney stones are becoming more common. They're a greater financial burden on the healthcare system, but we're developing more advanced, efficient, and safer strategies to combat this disease. Thank you very much.
Yep. Okay, Andrea. Andrea is up next.
Good morning, everybody. My name is Andrea Staack, and my accent gives us away. I'm from Germany, but California adopted me. I came here many years ago and found my new place at Loma Linda. And Loma Linda University has been an extremely good source for me to develop and hone my interest in holistic medicine for women's health and urology. When I arrived here, I found great minds to partner up my ideas to make the care for women in urology better. And I partnered up with Dr. Sabate from the Department of Nutrition, who is very well known for his findings on walnuts and how diet has an impact on overall health. And Dr. Diestelberg, who is an expert in family counseling. And we together designed a study for medical students and my own elderly patients, and evaluated the impact of coffee on urinary frequency, coffee on sleep, anxiety, and stress. I will talk about those findings also today. I also found a good base and help by partnering with medical students. I'm mentoring medical students since I arrived here with great pleasure, and I see them growing, and eventually they will be sitting here as well. And with the help of the medical students, we also conducted a study in the fields here around Loma Linda, and we went to CrossFit centers and looked at high-impact exercising and the effects on staying dry during CrossFit exercising, and I will present those results. When I started here, Dr. Roger Hadley has been a mentor of mine, and he opened my mind also to use alternative methods when I treat women surgically for urinary incontinence. And as you know, that the FDA came out with warnings that synthetic material can be harmful for treating women with pelvic floor conditions. So we were looking at alternative options and explored the use of their own tissue, the vaginal epithelium itself, which I will report. And in Dr. Baldwin's team, I found help and inspiration to develop different techniques when we do radiological assistance intervention in the OR to have an open mind to reduce radiation for everybody's safety. Now let's talk about the specifics. So urinary incontinence is not the coronavirus. 13 million Americans are affected by this condition, unfortunately. It's very expensive. People spend over $26 billion a year to buy pads or depends or devices to protect themselves and others. It's very expensive and it's a social problem. In Japan, it has been reported more people spend money on diapers in the adult life than for their babies. There are two major types of urinary incontinence. One is urge urinary incontinence, which is basically an involuntary loss of urine based on sudden contractions of the detrusor muscle, what you can see here at the urodynamic study. And it's related to age, hormonal changing in human bodies, related to diet, coffee, soda, alcoholic beverages can increase this condition. Smoking, psychological stressors, and neurogenic conditions are related to urge and urge urinary incontinence. The treatment options are plentiful. Behavioral modification is very dominant in my practice, to take the time to talk to patients to identify the possible culprit of their condition. And pharmacotherapy, in addition to behavior modification, is not working. We have advanced treatment options. Stress urinary incontinence, on the other side, is related to weakness of the pelvic floor, as well as the urethral sphincter mechanism, and can cause to involuntary losses of urine with certain pressure changes, activities, which can be seen in women who had vaginal deliveries. Also, as I mentioned, in women who are doing high impact, fast changing motions and exercises related to that, chronic coughing, extra weight on the pelvic floor, and obesity can cause this condition, as well as pelvic surgery, such as hysterectomy or prostatectomy. Weight loss is very important to decrease the abdominal weight on the pelvic floor, and physical therapy to strengthen the pelvic floor musculature. What we also seen sometimes, it can be helpful to have a pessary placed to give the urethra an extra push, expectation management, or surgery. So now let's talk about more what we found in our coffee study. First, we conducted a study where we enrolled 49 medical students from Loma, and half of the group was dedicated to drink coffee, freshly brewed coffee, which contains about 450 milligrams of caffeine. And the other group was asked to drink decaffeinated coffee, which contains about 12.5 milligrams of caffeine. And after 5 days of treatment, and that was after a washout period, we asked patients or our medical students to fill out questionnaires on their symptoms, and we saw that there was a significantly increase of symptoms of urgency and frequency in the coffee drinking group, which you can see in the white graph, compared to the decaffeinated group in the gray graph. Interestingly, when we stratified for previous caffeine use, our medical students who never or very rarely were exposed to the impacts of caffeine had more symptoms. So habitual coffee drinkers were a little bit more protected for frequency and urgency associated to more coffee intake. In the same group of medical students, we also looked at anxiety levels and sleep, and found that the coffee drinking group had a more reported sleeplessness and greater anxiety. The literature gives us abundant information nowadays on mindfulness, how relaxation techniques, visualization techniques, and breathing can improve the urge and the urge urinary component. This is also what I found out in my elderly population. We enrolled over 200 elderly women above the age 58 to 91. And in this group, we found that patients who were more connected in their social environment and had more support in their daily life were less complaining about health issues related to their overactive bladder. That was very interesting. So a person who feels lonely or depressed and doesn't have the social support seems to be more affected by the symptoms and the bother related to those symptoms. So if those behavioral changes are not satisfactory or sufficient to the patient, we are advancing the treatment, and sacral neuromodulation has been shown to be another treatment modality for those patients. Sacral neuromodulation is like a pacemaker for the bladder. That means a lead gets inserted in S3, which at the sacrum, and it's targeting the sacral nerve roots, which then improves the communication between the nerve and the detrusor muscle of the bladder. Since we are trying to decrease the risk of radiation, we tried the low-dose radiation technique in those patients. And we found in 30 patients that when we used reduced fluoroscopy, which is basically instead of targeting the patient with 30 pulses per second, we reduced it to 1 pulse per second, we were able to show the same landmarks anatomically which are sufficient to place the lead successfully at the right place. So by 5-fold, we were decreasing the fluoroscopy time in those patients. So let's talk about treatment of stress incontinence. And I mentioned before that certain types of exercises are more prone to increase urinary leakage. So I wanted to learn more how women are doing who are exposing themselves to high impact exercises like we see nowadays in CrossFit. So therefore, we enrolled over 115 patients in this study, and we found that almost 50% of them reported a leak, and they were all around 29 years old. So it's very common based on our human female anatomy, the short urethra and the relatively weak pelvic floor musculature. Women were more at risk who had a recent vaginal delivery. Certain exercises like this box jumping or the double unders and jump ropes were prone to the highest rates of leaks, which has something to do that there is high velocity and large pressure changes, and the pelvic floor cannot keep up with that. Participants reported that they would do some sort of precautions, and their measurements were to empty the bladder before the workout, to wear dark underwear and dark pants from the outside so that a leak wouldn't show as much, and to perform Kegel exercises, which means contractions of the pelvic floor during those specific exercises. Otherwise, women try to adapt and try to ignore that problem. If behavior changes, pelvic floor exercise are not sufficient, we then progress to a sling procedure, which is an anti-incontinence surgical technique where a hammock-style implant gets placed underneath the urethra. The synthetic mesh, as you can see on the left side, this honeycomb structure is the most used material for stress urinary incontinence. And here at Loma Linda with Dr. Rouse, we developed a protocol where we can visualize synthetic mesh in the vaginal area for evaluation. No other imaging modality is presenting us such good images than ultrasound. Since the FDA came out with the warning, I am not using synthetic mesh in my patients, even also not for the sling. We are using now autologous tissue, which can be harvested from the rectus fascia, which has been used for hundreds of years or more than 100 years, and the vaginal wall sling, which Dr. Roger Hadley and Dr. Baldwin started using here at Loma Linda many years before. But I was able to do a retrospective study on my patients. In over 200 patients, I compared the synthetic sling with the vaginal wall sling and the rectus fascia sling, and I determined the same outcome. So I'm very confident to continue using the vaginal wall material if available. In summary, lifestyle changes are the fundament in my practice to start any treatment with my patients, which has something to do to be more aware of the pelvic floor, straighten the pelvic floor with exercise programs, the help of a physical therapist, create mindfulness, counsel on certain beverages, especially coffee, pharmacotherapy, and if necessary, surgical treatment options, but adapted to our modern standards and on the safety for sure. Thank you for your attention.
Thank you very much, Andrea. Now, Brian Hu will go over an update on oncology, but you can see that urology brings it all together. You thought family medicine did, but urology is all about happiness, life, death, sex, and diapers. That pretty much brings it together.
Well, thanks for having me. I think I've already learned something today. I think I'm just going to have all my prostatectomy patients wear dark pants, and it should be fine. So today we'll talk about urologic cancer, what's new into 2020. And I think similar to a lot of fields in all of medicine, we've made a lot of great strides, but a lot of room to go. So what I'll talk about is we'll talk about PSA screening, because that's a topic that has wide-ranging effects. Talk about what prospective randomized control trials are out there looking at treating localized prostate cancer, and then dive into some of the lifestyle modification studies that have come out in prostate cancer, and also lifestyle impacts in other GU cancers. So what are the current recommendations for PSA screening? There's probably 3 different organizations that provide these guidelines. The first is the American Cancer Society, which does recommend PSA screening. They have different cut points based upon patients' risks and their ethnicity. But key in this is shared decision making. This means talking to the patient about what we know and don't know about PSA screening, some possibilities of false negatives or false positives. The American Urological Association has a similar recommendation, has a different age range between 55 and 69, they feel is the best at finding people with clinically significant prostate cancer. So that would mean the Gleason, any Gleason pattern 4 cancers. And then the U.S. Preventive Services Task Force, this was 8 years ago, they had downgraded PSA screening recommendations to a level D recommendation. So this is a big deal in urology, a big deal in cancer, a big deal from an advocacy standpoint as well for men out there who feel that PSA screening has been impactful in improving their lives. And the D recommendation was that the harms might outweigh the benefits of PSA screening. That has since been walked back 2 years ago to a C recommendation, similar to if you were a 49-year-old woman and wanted a mammogram. Similar recommendation that this should be offered selectively and that there's moderate certainty of a small net benefit. So where are we with what does this mean for our patient? What does this mean in terms of the general landscape of prostate cancer? And now this is a study looking at just the overall incidence of localized and metastatic prostate cancer, using 2012 as kind of a cut point of what we are seeing from an epidemiologic standpoint. We are seeing, with the arrow pointing at 2012, that as would be expected in 2012, the incidence of localized prostate cancer decreased. So this would make sense. If we're going to screen less men, we're going to detect less cancer. But the corollary here, and this is what a lot of older urologists are afraid of, and that what they saw prior to the PSA era, is the incidence of metastatic disease is also increasing. Obviously, you wouldn't see that immediately afterwards, but what we're seeing here is a reverse migration to more advanced disease. And with more advanced disease, you have those attendant morbidities. So you have patients with urinary retention, they have bone pain, problems with bulky nodal disease, blocking the kidney. So that's something that to keep an eye on with the change in the screening recommendations. What about new ways besides PSA? There's genomic testing, there's proprietary PSA testing, there's free PSA testing, but maybe we should be looking more at baseline PSA as a predictor of somebody's overall cancer risk over their lifetime. Now, this is a study out of the PLCO. This is a large study looking at PSA screening, and they looked at men just stratifying them based on their baseline PSA value. And you can see really drastically different curves if your baseline PSA is high or your baseline PSA is low. And maybe a better way that we should screen men is do a baseline PSA at an earlier age when it's more actionable, not when they're 70, 80, when it's probably not going to be worthwhile. And then using information gleaned from that first PSA to determine the right screening intensity, where some people might not need any more PSAs, some people might need annual PSAs, or some people might need a biopsy straight off. So that's something, a way that we're trying to improve PSA screening. Where are we in localized prostate cancer? So there have been probably 3 large randomized style studies out there looking at treatment versus no treatment. This is the largest one with the longest follow-up, the Bill Axelson study published in New England Journal. And I like this because the graph really shows you very well in terms of what the benefit of a radical prostatectomy is, and then in what time course, okay? So the benefit of the radical prostatectomy presumably is in overall survival or cancer-specific survival, but also potentially in preventing metastatic disease. So if you look at the graph on the top left, this is all comers who had a prostatectomy. The shaded area is those patients who ended up dying of disease. And if you look just to the right there, that's actually patients who did not get treatment. You can see a higher rate of mortality. In that second shaded area, a higher rate of people dying with metastatic disease. So what does this study tell us? This study tells us in men with a long life expectancy, this is follow-up 20 to 30 years, that radical prostatectomy was associated with an absolute increase in life expectancy of 2.9 years. Other studies, this is called the PROTECT study run out of the UK, is looking at radiotherapy, surgery, and surveillance, again, in a randomized fashion. So what you see on the left side graph is you should see 3 curves. You don't. You see 1 curve. What does that tell us? That tells us that in 10 years, the prostate cancer-specific survival is equivalent no matter what modality you choose. If you choose active surveillance, which is, again, is a management modality where you survey the cancer using digital rectal exams, PSAs, MRIs, repeat biopsies, and then treating them with a curative intent at the time of progression, that this management strategy is not associated with any decrement in overall survival. So that's a very good sign for where the field is moving towards more utilization of active surveillance. It should be noted this is men with T1 to T2 disease, so not the really locally advanced disease into the seminal vesicles or into the lymph nodes. Now, the graph on the right shows us that surveillance is actually associated with a little bit higher rate of progression. So that means maybe a bone metastasis or a lymph node that's enlarged or a rising PSA. So what we do know is active treatment with surgery radiotherapy has equivalent survival at 10 years. But that active treatment does lower your risk of disease progression and metastases. This is another study in the VA population where it does seem like radical prostatectomy has a little bit of a split from active surveillance, from death from any cause or death from prostate cancer. But when you do the statistics, this is not statistically significant, potentially because the VA population is a little bit higher risk, a little bit more comorbid population. Now, transitioning a little bit more into lifestyle, this is a study that came out just 2 months ago in JAMA, and really very large study, very large ambitious study, looking at the effects of behavioral intervention with increasing vegetable consumption on cancer progression in early stage prostate cancer. So really picking this apart, early stage prostate cancer, potentially a very good cancer for which to study the impacts of behavioral changes, right? It's not pancreatic cancer where patients already have advanced disease. It's not precancer, dysplasia, atypia. This is known cancer to see if what we think about vegetable consumption, what expert opinion in some epidemiologic studies and what some preclinical studies, if that actually translates to a meaningful clinical endpoint. Okay, does this mean that people with early stage prostate cancer, it's not going to progress as much? So how was this set up? This was about 500 men, 91 centers across the United States, and half got an intervention, half did not. Now the intervention is very well thought out. They used previously published methods to change patients' behavior. It's been validated in breast cancer, and they would give them 7 phone calls at different time periods and tell them to increase their intake of cruciferous vegetables and other daily fruit and vegetable servings. Whereas the control group, they just gave them a flyer and said, hey, vegetable consumption increasing may be associated with changes in or improvements in prostate cancer outcomes. And what did they look at? They looked to see if the cancer got worse, more or less. What did they find? They found no difference in upgrading. So patients' cancer histology did not get worse. No difference in the increase in PSA, and no difference in the PSA doubling time. So it was a negative study. So the interventions did not lead to a clinically meaningful endpoint in less cancer progression. So that was the negative study. What did it do, though? I think it was a very ambitious study. It was a very large-scale study, and they took dietary logs of how much vegetables these patients ate, and they actually validated it with serum or plasma carotenoid levels, and they found that this is the first big study that showed that, hey, over the course of years that we're able to modify these patients' behavior. So I think it's very commendable. Where does it fit within prostate cancer literature on lifestyle and supplements? It fits, it's pretty consistent. We've got large randomized control trials looking at selenium, vitamin C, vitamin D, omega-3 that do not show any impact in prostate cancer. And one, it should be noted that selenium seemed to be associated with a higher risk of prostate cancer. How about other the urologic cancers? This was an interesting meta-analysis of all the prospective studies out there looking at lifestyle impact in all cancers. And not only looked at all cancers, but looked at incident cancers, how often they got the cancers, and it looked at cancer morbidity and mortality. So once they got the cancer, how well did these people do? It compared the people in the highest quintile of lifestyle, the patients that had the least amount of smoking, the healthiest, best dietary, compared them with the worst quintile. And then this just obviously goes over a really vast number of patients, about 1.9 million when they're looking at incident cancers, and about 1.8 million when you're looking at cancer outcomes. So overall, for bladder, we saw about a 17% reduction in those patients that had the better lifestyle modifications. And actually in kidney cancer, it was more, 38%. And in prostate cancer, there was no difference. How about overall? Overall, there was about a 0.71 hazard ratio associated with the better lifestyle. And even more so, if patients got cancer, the hazard ratio was even lower, so 0.48. So the patients with a healthier lifestyle, from an epidemiologic standpoint, seemed to do better. Now, when taking a deeper dive into the urologic cancers, I thought, smoking and bladder is very strongly associated. I thought bladder cancer would be shown to have higher reduction, but actually kidney cancer has about double that of bladder, so we'll take a look into kidney cancers. So we know kidney cancer has a higher incidence in developed countries and in countries that have higher rates of obesity. And we know a little bit about kidney cancer pathology just by looking at the patients who had hereditary kidney cancer, looking at von Hippel-Lindau, Birt-Hogg-Dubé, and certain genetic predispositions for kidney cancer. But I think the lifestyle factors are getting a lot more attention, and those would be things like smoking, obesity, hypertension, and regular analgesic use. In terms of smoking, I think there's about a 24% risk higher risk if you're a former smoker, and this goes up to 52% if you currently smoke. This does appear to be dose dependent. I think metabolic syndrome has a much higher rate of kidney cancer incidence, about 4.4%. I'm sorry, not 4, about 4.4-fold, as does routine NSAID use. That's about 1.5 hazard ratio. It is dose dependent, and we don't really know which one it is. There's really conflicting data to see, is it really NSAID use? Is it really an NSAID? Is it aspirin or acetaminophen? Studies are really mixed in that regard. The one that is interesting is that alcohol actually has a protective effect on kidney cancer incidence. It was seen in both 2 prospective studies as well as 2 systematic reviews that looked at light to moderate alcohol consumption seemed to be associated with a lower risk of incident kidney cancer, so about 0.85. Some prospective studies that showed there's about a 25% reduction in getting a renal cell carcinoma. And one study said, well, if you look at women in wine drinking, it seems to be significant. Other ones it's not. We don't really know why alcohol is associated with a protective effect of kidney cancer. Maybe it has to do with a diuretic effect. but it should be worth noting that there's 6 other cancers where alcohol has a negative prognostic impact on the incidence. Obesity is the last one I'll talk about. I think there's a very strong risk of a link between the obesity and kidney cancer risk. This is about 24% in men and 34% in women. And if you are very obese, if your BMI is greater than 35, you get a 71% increase in renal cell carcinoma compared with somebody who has a normal weight. And this, we don't really know why. We would hypothesize maybe it has to do with their hypertension risk or some of the insulin factors. Paradoxically, when we look at once you get kidney cancer, who does better, it actually appears that patients with obesity do better. If you look at these Kaplan-Meier curves in 2 cohorts, it appears that the obese patients, their survival is better, at least in metastatic disease. We think that maybe this has to do with the fatty acid synthase pathway. Maybe it's because we're just capturing a lot of patients with cachexia in the non-obese setting, but this is also something that to look out for. So to conclude, today I've told you that the consensus on PSA screening ranging from 40 to 69 years of age is there among the national guidelines, but the shared decision making is key and that we're working on other ways to improve our risk stratification, including baseline PSA measurements. I've showed that randomized control trials have shown variable survival benefit for surgery and radiotherapy compared with surveillance. I think with longer follow-up you would see more, and higher risk disease you'd see more of a benefit. And that we have concluded a large behavioral modification trial that showed the proof that we can modify behavior in patients, though it did not lead to any significant clinical endpoints, and that there's emerging lifestyle factor impact in kidney cancer incidence and survival.
All right, good. Thank you, Brian. So we're going to do questions now the way that we did it before, but first I'd like to make a couple of comments about this. One is the screening question is an individual question, and so I think what he emphasized about shared decision making is the key, because prostate cancer, death from prostate cancer isn't the culprit as much as bone metastasis from prostate cancer leading to death, because there's a lot of misery involved, so prevention of metastasis is key. Being here at Loma Linda, I get a number of patients that want to come and talk about dietary intervention for their prostate cancer. It doesn't work. And some of these are people that have even been to medical school. And once you have a cancer, DNA mutations have taken place that do not lend themselves to dietary intervention. I mean, that sounds apocryphal, but it's true. We live in the real world. And I think the important thing is using diet to prevent prostate cancer. Belly fat is bad. High BMI is bad. Belly fat and high BMI lead to more prostate cancer, more kidney cancer, and to more aggressive prostate cancer. I was just looking at a study that recently came out, that just came out on that. And so this is a lifestyle modification that happens early on. You can't backpedal and rewrite history once you have prostate cancer. And I think the meal study is good validation of that. I would like Dr. Baldwin, I want somebody to ask him a question on the gut microbiome and kidney stones. And I would like somebody to ask a question on sleep apnea and nocturia, because sleep apnea, remember, goes to metabolic syndrome and obesity. So Dr. Reichert, with that, we are ready to answer any question that we can on anything. Don't be shy.
Yeah, there's a lot of primary care doctors here, and I've been thinking about this as well. But it seemed to me that most doctors, when there is kidney stones, and I'm not talking about something that's complicated, just a simple kidney stone, typically, you'll give them some Tamsulosin, some Flomax, and you also give them a handful of Percocet. It seems that maybe changing, but it seems to me that most physicians do they is there evidence out there now saying, hey, look, Flomax and ibuprofen will probably be good enough, you know, and I'm not talking in the context of uteroscopy or as well or anything like that, but just, you know, which most kidney stones I deal with, I'm just going to give them some medicines.
Yeah, so that's a great question, and one that is a subject of quite a bit of debate right now. And I think there is emerging evidence that, you know, traditionally we've all treated kidney stones with narcotics. You know, we thought it's the most intense pain there is, and ranks equal to or maybe perhaps worse than child labor, and you don't get a baby at the end. So most people view it as the worst pain there is. So if that's the case, you know, if it's the worst pain there is, you'd think, well, you'd have to give them narcotics. But you have to weigh the risks and the benefits of any therapy that you're going to implement. And in this case, the risk is if you give a patient a prescription of narcotic pills, 1 out of 10 of those patients is going to become narcotic dependent for the rest of their life. I have a patient right now who is a nice Adventist, retired pastor, the sweetest guy in the world, and he is on hospice because of no other reason other than he got some narcotic pain pills when he had a kidney stone, and he is now so addicted on such high doses of narcotics that his intestines don't work anymore, and he is dying. So in my practice, we are not prescribing narcotics for kidney stone patients. We try to manage them without, and you know, there's been several different studies, one from Vanderbilt, one from University of Vermont, and they have looked at how do the patients do with no narcotics. They have a slight bit more pain initially, but their outcomes are just as good and perhaps slightly better because they have less of the narcotic-induced side effects like constipation and ileus and all the other things. So I think I would encourage you to try in your practices not giving narcotics, giving them a combination of Tylenol with Motrin, having them alternate, having them use hot packs. They actually, in Europe, they routinely for kidney stone patients don't give them pain medicine, they give them a hot pack, and it actually is quite effective. It does work.
In patients with prostate cancer who are getting hormone therapy and their PSA is in normal range, are there any studies for long-term Viagra use, if that affects the cancer in the long term in any way?
The long-term Viagra impacting the biologic, the natural history of the prostate cancer? No, I do not think so. I think, you know, if you're on hormone deprivation therapy, the quote-unquote normal PSA should be, you know, very, very close to undetectable. If it's not, we'd be concerned for a castration-resistant disease, but I don't think there's, you know, much impact on Viagra on impacting the cancer.
Question up here.
Yeah, I want to hear the answer to the microbiome question.
The most common type of kidney stone is calcium oxalate, and there's a bacteria that is in the gut called Oxalobacter formigenes, and so there's been a lot of research, like particularly in China, looking at patients who have kidney stones are less likely to have that bacteria in their intestine. And people who have that bacteria in their intestine are less likely to get kidney stones. So there certainly is pretty good evidence that that is an important bacteria, breaking down oxalate and reducing the absorption of oxalate. And so it's good to have it in your microbiome. So now the question is, how do you get it there if you don't have it there? And I just recently saw a study where they tried putting it in there, and it wasn't very effective. So you know, probably the best thing to do would be to eat a good diet and avoid killing it off, so that it's there in the first place and you don't have to repopulate it.
Is there any evidence showing that dietary dairy restriction reduces the incidence of prostate cancer?
I was going for the mic. I thought that was going to be kidney stone, but
I don't believe so. Dietary dairy. I'm trying to think of what the pathophysiology behind that hypothesis would be, but I'm not aware of any.
There has been some written about that there is, because of I think it's the protein casein that is in dairy that does increase the risk somewhat for prostate cancer. I think that the emphasis should be on a very broad, foundationally based, plant-based diet. And so if you're trying to get a good microbiome, eat a lot of different things. And for prostate cancer, eating a little bit of Greek yogurt for your Mediterranean diet probably isn't going to be the deal killer, but drinking, 3 glasses of milk a day, would probably correlate to an increased risk. I think that one other thing that I want to emphasize about Dr. Hu's slide is that we have cancer incidence and then cancer mortality. So taking the lifestyle seriously for a good diet and being healthy with moderate exercise, good sleep, and being healthy decreases your cancer mortality. So it's protective in that if you get cancer, I could think of it as cancer doctors, we have more to work with, and you're going to do better if you're healthy versus if you're not healthy.
Question on PSA, the baseline PSA. At what age are they defining baseline?
In that PLCL study, they did not define, what age, but I've seen retrospective studies looking at doing PSAs as early as 40 to the 50 age range, and those should definitely, at that age, should be less than 1. So in that population, that one, if you're less than 1, you would argue that patient does not need any further PSAs, or maybe a PSA in a decade or so later. But if they have a PSA greater than 1, those ones you need to follow sooner. So that's the earlier studies are looking at that algorithm for treating them, but those have not necessarily been validated thus far.
And I would comment about that. I was recently just at a meeting where I was hearing about the new guidelines that are coming out and talking about genetic testing. And it was shocking that I think I saw some data that germline mutations in prostate cancer were about 25%. That's totally different information and thinking that we've had. So that means not looking at the tumor, but looking at the actual DNA of the person, not the DNA from the tumor. And that's way higher than the 10% that we thought. And so there's going to be new recommendations for germline testing, but it goes back to who would be born with a DNA complement and metabolism that would end up with a higher PSA when they're young. So I think that you're going to see it coming back to PSA testing probably at 40, especially if you have any first-degree relatives that have had not only prostate cancer, but breast, ovarian, colon cancer.
One more question. 2 more questions, I'm sorry. See how popular you are? We're trying to build you up since you're the #1 burnout guy. So we want to show you some love with these questions.
Thank you. We appreciate that.
This is a question that was not addressed during the presentations, but what lifestyle modifications can you recommend patients who have or is diagnosed with interstitial cystitis?
Thank you for that question. Indeed, that's a wide field and it's a very changing field. And I had this discussion this morning with Dr. Ruckle because we believe that interstitial cystitis is not the right name for this condition. Interstitial cystitis is or should be only used as a medical term when a patient has been found with Hanna's ulcers and a small bladder capacity on the bladder. Otherwise, if the bladder capacity is normal, if the patient doesn't have any ulcerous changes in the bladder, we shouldn't call it interstitial cystitis. We should call it chronic pelvic pain syndrome. And chronic pelvic pain syndrome has a variety of origins. So it's essential that we sit down with the patient and find out what a possible origin could be to then start addressing that traumatic event. And such a traumatic event can be a sexual insult, but it also can be as insignificant as a urinary tract infection, like a bacteria infection, which can cause pelvic pain as a syndrome. It also can be related to a stressful period in somebody's lives where the bladder as a storage reservoir for body waste, including enzymes, stress hormones, can be targeted and triggered, and neurological feedback mechanisms can then start like a circle of pain. So to differentiate that and to find out the basic stressor which analyte can help to start the patient at the right treatment. So I wouldn't start to take kind of putting the patient on antibiotics if the patient doesn't have a positive culture. I would start talking to the patient and finding out that there are no other underlying conditions in the bladder. And then we talk about mindfulness, relaxation techniques, pelvic floor exercises, increasing their fluid intake, trying to target their stressors and work on this area.
So we have a question in the back, and then
And one thing to add, and we would never put that patient on narcotic pain medication. Is that? Yeah.
Are there studies comparing saw palmetto one-on-one with the standard prostate medicine in terms of alleviating the hypertrophy symptoms?
Yeah, there was a prospective randomized study showing no benefit of saw palmetto compared to placebo, which flies in the face of what all our patients tell us, because I'll tell you that I have many patients who swear by it and say it works great, but the prospective randomized study showed no benefit.
But we love saw palmetto because if the patient believes that it works, because it does not cause harm. It doesn't cause harm, so it's not dangerous. So we love it when it works.
one more quick question here.
Rick? Dr. Hu, 3 questions about prostate cancer. 1, did I hear you say that anything Gleason 4 and above is high grade? That was your statement?
I said clinically significant prostate cancer would be made up of anything that has that 4 component, so like a 3 + 4, 4 + 3.
Okay, so it's not a total of. Okay. Second thing is, perhaps you covered this, but I kind of recognize this is the Hopkins study where they followed low-grade prostate cancer for 15 years, found 1% mortality. Was that maybe you had the author up there and I didn't recognize it?
There's the Hopkins pathologist named last name Epstein. He has certain criteria for what they call "quote unquote" clinically insignificant prostate cancer. That'd be small volume 3-3, and those are the ones that basically do not metastasize, do not kill people.
Okay. And last question: when those of us in the community order a free PSA, there's a little chart that comes up that says if the number is below this or above that, this age, that age, chance of developing cancer. Is that any prostate cancer? Is that metastatic prostate cancer? Is that what subgroup of prostate cancers are they referring to when they report free PSA levels?
Yeah, the free PSA level, the subgroup it was studied and validated on a patient population that has already had a negative transrectal ultrasound guided biopsy of the prostate. So in biopsy naive patients, technically that free and total PSA is not validated in that cohort.
Okay, so if you're using it just to have an elevated total PSA, you go back and look at the free PSA, then that particular test not been validated in that particular group of people, is what you're saying?
Correct.
Yeah, and it's for use in the 4 to 10 and 4 to 10 range, and it would be any cancer, low grade, high grade.
Okay, so it's not as prognostically helpful as it was originally thought then?
It's still not bad. I think now there are other tests called like a 4K score or PHI or the MRI in that disease space that have a better AUC in terms of their usefulness for clinically significant cancer.
Sure. Thank you.
Thank you very much. I think you are masterful at bringing lifestyle into your field. And I appreciate addressing lifestyle in situations maybe where it doesn't work, because sometimes we start to think it does everything, right? So I appreciate bringing that. And let's give them a big round of applause. We need to show them our love. We don't want them to be number one in burnout.